You very kindly asked me to give a talk about the development, present status and future of deformation imaging in the heart. And I think this is a fascinating area for people. We have a problem in defining function. And traditionally we've used a combination of measuring from the M mode and 2D image, but mostly based it on our visual appreciation of what moves and what doesn't. Indeed, stress echo has been based on visual assessment for the last 20 years. To try and get around this problem, we developed a quantitative tool which could let us look at heart function. And that was based on initially myocardial Doppler and subsequently on tracking points within a 2D image to measure local thickening and thinning, the rate of thickening and thinning, and the peak thickening and thinning. Now, this has been developed, entered clinical practice, and is useful in a number of clinical conditions. The problem is that we don't resolve completely data at low frame rate. And currently we're trying to develop high frame rate techniques up to 4,000 samples a second that will let us measure indices of function in 3 dimensions in real time and fully resolve everything we need to. Firstly, I had the idea to base it on tissue Doppler because Doppler would let us measure velocities. But Doppler is an angle-dependent technique, so velocities themselves weren't truly estimated. The angle of inclination was a problem, also overall heart motion was a problem. So we developed this tool, strain rate imaging, which allowed us to compare 2 velocity profiles between 2 very adjacent portions of myocardium. And the difference in velocity between these would give us the strain rate, the rate at which the myocardium deformed. And its integral, strain, was also the amount. So we could measure how fast things happened in local segments and how much it happened. And this let us look at both radial function of a segment and longitudinal function. And these were new concepts. Now, many cardiologists don't realize that contraction is over by the end of the first third of systole, yet thickening occurs late at end systole. So the rate of thickening, or strain rate, peak rate of thickening, occurs very early, and it induces thickening, and the degree of thickening will be dependent on the loading. And something that cardiologists don't think about often is how function, local function, is interrelated with loading and the elastic properties of the myocardium. Now, we cannot measure true contractility. That's impossible. But we can look at contractile function by looking at strain rate, because peak strain rate is relatively load independent. So this is the index we really should measure. Strain is so load dependent that, for instance, a ventricle can be like this. Traditionally we've said this is poor function, but this is an extremely hypertensive patient. We control the blood pressure and function is this, and we say contractility has improved. It hasn't. We've just taken loading away. So true contractile function is very difficult to assess if loading changes enormously. So in terms of practical things, what can we do? Well, all the machines give you the option of using automated function analysis. And this is the machine processing the data you take. Previously, in the early 1990s to perhaps 2000, we had to take the data and we used to measure it ourselves. Now with the automated tools, we take away the individual influence on measurement and we can actually look at curves generated solely by the machine. Now, done properly, this is very effective, but you have to know a little of what you're doing, but it's become a much more practical tool. Indeed, many people suggest that ejection fraction, which we have traditionally used as our measure of global function, is much more reliably estimated by looking at an entity 2D longitudinal global strain, because this appears to be much more sensitive at detecting abnormalities of function. In the past, we've always looked at how the ventricle contracts in other words, radial function. But the ventricle is a pump, and the base moves to the apex, and changes in longitudinal function precede, in disease states, changes in radial function. Radial function compensates for a reduction in longitudinal. So by now looking at global strain measured in the long axis direction, we have a much more sensitive and reliable tool at looking at malfunction and also changes or improvements in function with therapy. Another advantage of the equipment development over the last 10 years has been the same equipment can be used, say, in Belgrade as could be used in London. And because the algorithms are the same, we would expect the same results to be obtained from the same patient in Belgrade, in London. It takes away, to a large extent, the observer error and the problems in data acquisition, although you still have to do it properly. But it's a much more generous tool, if you like, giving you, we would hope, the same result. And studies are starting to appear which suggest that. One of the problems, however, being machine-based, is not all companies use the same algorithm to define the same curve and the peak value. And the European Society is looking into this with the companies so that there is going to be a uniformity between companies of how and what they derive. And again, this will strengthen the tool as a globally useful tool. There is work still to be done. Neither are perfect parameters. The ultrasound machines can still be significantly modified to take better data sets. Grayscale imaging can be improved upon. The algorithms, one of the algorithms I worked with hasn't been changed since 1997. It's still the same. People have not improved things because they felt that clinicians were happy with what they had. I think we as clinicians have to define what we need and what we want and lead the manufacturers to change their philosophy. Currently, we tend to have tools given to us which we're asked to use, but they may not be the best tools. So a better dialogue between manufacturers, equipment manufacturers, software writers and cardiologists will lead to enormous developments. But already we're starting to see very high frame rate imaging implemented in experimental setups. I expect within the next 5 to 6 years this will be in every clinical machine.